I don't know, getting from Japan, Kanagawa Children's Hospital. Um, Maybe we have arrived at the time to start. And please, Dr. Ueda, you may start the lecture. Thank you.
Thank you. Morning, everyone. My name is Hideaki Ueda from Yokohama Cities. I'm now working at the Canada Children's Hospitals, and it's my great honor to be here and join to questions. And I was just had a great time staying in Jakarta. Let's visit to be here from the Saturday morning. I just attended to the eye watch. So I would like to start my topics of the basic knowledge for reading monitor electrocardiograms. Maybe some of you may be very curious because I invited as an advisor of the catheter interventionist, but Dr. Winder had also required me to have many fields of talks. So I have just prepared myself. So I would like to start my thoughts. So what we can learn from the ECG monitors who are checking for the heartbeats in the children's. So first of all, we just focus on the pulse heart rate. We found why the pulse rate is so important. And the second talks is about how to interpret cardiac dysarrhythmia, which means that specific ways to recognize cardiac dysrhythmia and their clinical significance. And third is to build the actual ECG monitor to identify triggers for noticing cardiac dysarrhythmia. So what are the reasons to monitor ECGs? The majority of the basic reasons, the main reasons, is to monitor electrocardiogram and to understand to the cardiac arrhythmias. And just talk about the heart rate. So as you know, the pediatric vital signs are different from depends on each age. So whenever we see the neonate or maybe 6 months, under 6 months, maybe children around 1 or 3 years, 3 to 12 years, and over 12 years, and each of them has a different respiration rate, maybe heart rate, maybe systolic blood pressures, and mean blood pressures. So we always consider the about the age of which categorize was the patient has been belong to. So each patient would have a specific normal rate, or maybe specific heart rate, or maybe specific systolic blood pressures, or maybe specific mean blood pressures. So the first question, this clinical question is, are children resistant to tachycardia? Of course, the answer is no. The amount of blood pumped in a single pulsation is very limited. It's very small. And they need to increase the number of pulsations. So as you know, in the septic shock, the tachycardia often precedes the fever. In the chronic heart failure and dilated cardiomyopathies, the faster the pulse rate, the higher the motor rate will be considered. So if you found that if the patient had a 100 beats per minute and it arose to 200, it should be something wrong. If for the school age or adolescent persons who has a mainly 50 beats per minute and jump up to 160s, which is triple, that means also something wrong is happened. So this is the chart of the pulse and the body temperatures. As you can see, the temperatures doesn't seem change so much, but the pulsation has a jumping. This was the septic shock, which shown that the body temperatures was around 12 hours later than the pulsations. So sometimes the pulsations moves very quickly, which never found the high temperatures. But whenever we see the high rate of tachycardia, we always think about the possibility of the septic shock. And what is about the cardiac dysarrhythmia? I would like to show the pictures of the electric conduction systems. As you know, it's always start for the sinus node, and those beads were connected or uh, trans, uh, transferred to the LV node, and then it was moved to the bundle of the heads, and then go to the right-sided branch and the left-sided branch, and the Purkinje fiber is something around here. So ideally, the P wave, which means for the atrial contraction, should be followed by the QRS, which means the ventricular contractions, as we can see from this right-sided pictures. So this is the image of the premature atrial contraction. We call them PAC. A rhythm is produced in other atrium at the faster time than the normal RR interval. As you know here, the abnormal A rhythm will be produced at this place, and it will proceed, the P waves also proceed something like this. But still, the QRS shape is the same as usual because it's use the same conductions. Electric conductions is the same as the normal patterns. So as you can see, you see the two types. This is the normal types, and this is the PAC type here, but the QRS is the same one. And sometimes those abnormals P will be happen during the P wave, so it will be on the P wave, something like this. The another pictures is the premature atrial contraction of PSC. A reason is so this is the pictures of the PSC with blocked. As you can see, usually the sinus nodes will pass the electrical signal to the LV node, something like this. But if the too fast PSC was happen, which caused the LV node blockage, and the QRS would not happen. The only P wave could be observed, but no QRS will be observed. Something like this. If the RR interval will be prolonged. So looking at those pictures, we always see this. This is the because of the PSC, but the QRS was blocked because of the too fast timing had entered to the conductions, which were not able to conduct to the peripheral side. So this is the pictures of the premature ventricular contractions. The abnormal fund's eighth rhythm is proceeded into the ventricles at a faster time than the normal intervals. So always in these patterns, the Q waves do not proceed the QRS. And also the QRS shape is wider. As here you can see the P wave, QRS, T wave, P wave, QRS, T wave, but only wide QRS in here. And later on, there you can see the P wave, which is abnormal patterns. it would be like something like this. So PAC or PVC identification procedures is that notice that the RR space is regular and find the QRS with clearly fasting time compared to the RR interval. Is the QRS shape the same as usual or different? If PAC, if it's the same as usual. QRS, PAC or PVC if it's different from usual. Are there any proceedings P-wave? Looking at this point, we can evaluate or distinguish between the PAC or PVCs. Over here, you can see this is the normal P wave, but the very short interval here, PAC, and the normal patterns of the QRS, but the abnormal PAC here is something like the bigeminal pulse. We call them bigeminal pulse. Normal, abnormal, normal, abnormal, normal, abnormal patterns. So this is the same patterns as the QRS happens. Sinus and PVC, sinus, PVC, sinus, PVC. We call them bigeminal pulse or PVCs. So this is the P wave here, normal P wave here, normal P wave here, and then there should be maybe abnormal findings here. So this is the aberrant conductions of PSC bigeminal pulse. PSC timings is too early result in wide QRS here, which means that this is the normal pattern case, this is the abnormal patterns, but still the PSC is a little bit early, so it doesn't use the normal conductions. So always the conduction delay will happen, shows the wide QRS patterns. So narrow QRS means from the atriums. Wide QRS means from the ventricles. So the question one is, we can QRS with differentiates between the supraventricle and ventricles? The QRS within alone cannot differentiate it. And this is a very important point because the aberrant conductions with wide QRS like IRBBB would happen. So here this is the normal P wave here. This is the QRS normal patterns. But if it's from the abnormal P here and the aberrant conduction, the conduction will happen, it looks like a wide QRS. So whenever we see the wide QRS patterns, we could never see that this is PVC. We just have to see where the P wave are. And so I would like to say that supraventricular could make wide intervals, which means that there is an aberrant conduction delay, maybe antidromic AVRT maybe suggests, and also the ventricle could make narrow intervals because VT maybe around Parkinson fibers look like narrow QRS. So here I would like to pictures of the aberrant conduction. If the too fast PHC happens, it blocks the right bundle branch, so the left bundle branch is conducted. So it was the PHC would happen, but the QRS is abnormal patterns, so it's looked like a PVC here. So the clinical significance of PHCs and PVC and tachyarrhythmias. The treatment is not always if the conduct is very stable. However, it may be a sign that something is not right, something wrong has happened. So what we should suspect it? Maybe the patient is a post-operative natural cause. Maybe there is an erector-like abnormality. Maybe there's infections. Maybe it will show that it has a possibility to worsen heart failure. We have to always think about this. So this is the very typical ECC patterns of PSVT, paroxysmal supraventricular tachycardia. Generally, those kind of the arrhythmia is the indication for treatment. So how does the extrasystolic affect hemodynamics? The bigeminal pulse of premature ventricular contractions. The blood pressure is not never very high, but there is almost no cardiac output during the PVC. Normally, this doesn't cause any kind of problem, but if it could be after open heart surgeries, we have to always think about it. Whether the CVP is increasing, or the urine volume is maintained, or the lactic acid is normal. If there's, for example, if the CVP is getting increasing, or if the urine volume decreasing, and if the lactic acid has increased, we have to maybe go further for the treatment. So blood pressure can be confirmed when in the sinus rhythm, but not in the PVC. That's a very difference from the PAC and PVC. So the enough blood pressure does not mean hemodynamic stability. So here, this is the respiratory fluctuations, which if the patient is below the 6-year-old, there is a very those RR interval will be affected by the respiratory phase. But still, if the patient grew out, those kind of the fluctuation will be this decrease. So in the 10 ages, we will be harder to see this kind of the phenomenon. So this is only for this young children. So what's the heart rate variability analysis could mean? The evaluations of the degree of beat-by-beat variability of the heartbeat is very important because the greater the fluctuations, the more dominant the parasympathetic sympathetic nerve system is working. If we found the loss of heart rate variabilities, mean that it indicates sympathetic dominance and is a poor prognostic factors for patients with heart failure. So whenever we see if the heart rate rose and then if there is no heart rate variability, it's a very bad conditions. We have to move to for the further treatment. And here there is a picture showing the heart rate variability analysis. As you can see that if the mothers with hold and mother with hug and the tight hug, there's no numbers of very shown, but still, as you can see that the gentle hug shows the most good effect for those babies. And if the strangers will hug and it will save the parents, what we can find very interesting that the baby tends to love mom and dad. So those hugs from parents fluctuate more than strangers. So the louder the bar, the greater the heart rate variability means. So it should be good for the babies. So this is the pictures of the wandering pacemaker here. Looking at the two wave here, you can see this is the positive P wave, positive P wave, positive P wave, and the later on, this is the plus minus, 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 minus. So we can see here, there is a at least three patterns, plus, plus, minus, minus. But still, its use is normal conductions. So that's why the cure is maintained. We cannot find any difference from each pattern, which is conducted by this three type of different P wave. So why is the tachycardia so bad? So looking at the pulsations or cardiac output, if the cardiac heart rate will get aroused, something like pulse, the cardiac output, initially it will go aroused because it can get, uh, uh, if there's simulation that reaches the heart rate, the heart will be start to beating strongly, but still, as once it will reach to the maximum part of the cardiac output, then even the heart rate will be get accentuated. The cardiac output will uh, get decreasing gradually. So if the pulse heart rate is increased too much, the cardiac output will get decreased. This is the very important pictures. We should always think about it, put in mind. So what is the cardiac output? It's that one beat output lined by pulse rate. However, the cardiac output simply does not increase by the amount of the increased pulse. So looking at the atrial tachycardia, think about it. Instead of the sinus node, another part creates the rhythms here. The abnormal P will come here, and those pulse is often too much, but still the atrial kick is maintained. So the blood pressure will be maintained. But as you know, in the DC, it doesn't stop. It wouldn't help so much. It will conduction something like this. So curious patterns is normal as usual. Here you can see the P wave looks like very similar to the normal patterns. But still watching is very carefully. It's a little bit different from the P wave is a little bit different. So we can distinguish that. Oh, this is the AT of P wave, this is a normal P wave. So why is tachycardia so bad? Figure on the left shows us the blood flow through the mitral valve. The A wave is blood filling in the left ventricle due to atrial kick. There are two ways to fill the left ventricle with blood. The left ventricle dilates to passive fill with blood. But secondly, the atrial contraction, atrial kick push blood into the left ventricle. In normal hearts, it's responsible for 20 to 30% of cardiac output. But arrhythmia disrupts the atrial ventricle rhythm and prevent the benefit or the atrial kick. So this is the very serious abnormal arrhythmia, which is well known as if we found, it is well known that if we found those kind of the junctional tachycardia, we call them JET, during the post-operative stages of phantom circulations, those kind of the patient will be suffered from the very severe heart failure and should be very difficult to get survived. So initially, we should stop it as soon as possible. That maybe put in the amiodarone, or maybe to put the intubated and keep it hypothermia, because there are not so many efficient ways to stop it. So we always have to. We cannot never dismiss. We have to be, keep in mind that this would happen in any time after the front operation, and soon as possible, if we found those abnormal findings, we should go for the further treatment. So the mechanism is increased motility from the junctions, and this kind of the tachycardia is very unique because the atrial kit is not maintained and does not reply for the ATP and does not stop for the DC, which means that the usual treatment does not work so well. But as you look at the ECG monitor, the QRS shape is same as usual. Here, there's a negative T wave here that means that it is retrograde P wave. But still, the QRS patterns looks like the same as usual. So this is often overlooked. So we have to be very carefully checking what's the P waves are. Whenever I see the retrograde P wave, the thinking about the possibility of the jet should be not so difficult. So again, why is the tachycardia so bad? Ventricular tachycardia and the ventricular pacing do not pass through the Purkinje fibers. So it takes time for electricity to flow throughout the ventricles. So as you can see, it happens something around here. The other places will get late to get contracted, which means that the timing of the contraction is not safe. So it's loss of energies. So here's the ventricular tachycardia, and here's the ventricular pacing, which we have to, if we could able to pacing, we could make those contractions in the same time, and that's a very good way to treat with them. So whenever we think about the ventricular pacing, maybe in some patient we could think about if the patient could be pacing from the atrial, that should be better. So if not, we will always think about if we place another place of pacing, and then if we could do the simultaneously to make the contraction timing the same. And it should be very important for us. Ventricular tachycardia VT is a very arrhythmia, as you know, because the atrial kit is not maintained and does not stop for ATP, but it sometimes stops for DCs. So QRS shape is wider than usual because inefficient ventricular contraction due to lack of Purkinje fibers. So it should be not so difficult for us to understand why it's so bad. So how we should respond to arrhythmia? Is hemodynamics failings not acceptable if blood pressures persistently drops? So we have to, at that time, start chest compressions as soon as possible, and then we should go for the defibrillations or DCs. So ventricular fibrillations is worst things. It's a lethal arrhythmia. The ventricles quiver and unable to pump effectively, which does not respond for the ATP. So immediately we should start the chest compression and then move on to defibrillations. With the QRS shape does look like very floppy, which means that contraction does not move in so much. So about the defibrillations, the infant in the airway pass, the correct placement should be in the front of the body and the back, which means that it should be sandwiches. So we don't have to place it something like at the right sided and the left sided. This should be a little bit larger case, but still in this infant, just only put the place in the front and it's on the back to get sandwich the heart. But the most important thing is to start the chest compression as soon as possible. And if possible, give the 2 or 4 joules per kilograms. And then even as soon as you give the defibrillations, please start the chest compressions. This is the synchronous undercurrent disease. Electrically stop the heart once. If sinus rhythm is restored to predominance afterwards, the patient would improve. It will be effective for reentry but 80 is not effective and also not effective for jet. Just give only 1 joule per kilograms. But anything that lifts the heart, that's the most important things for even for the small kids. So in case of the tachycardia, we have to think about such mechanisms. If VF or strong hypertensions are appeared, how rapid is the tachycardia prolonged, and how long does it last? And then we should go for the differentiation if hemodynamic collapse or disease. If not, just do the 12 inductions, ECG and bucket. If no diagnosis made, first of all, we should give the ATP administrations and then evaluation with pacing leads and esophageal leads if possible, and then go for the treatment. First of all, we should defibrillation or synchronize energizations if hemodynamics are not stable. If stable, electrolyte compensations, deep sedations, lower body temperatures might work very well. Also, we have to think about the pacing treatment. Or finally, antiarrhythmic drugs. I would like to talk about the actual ECG monitor. Here, there's a very typical ECG strip here. And here, there we can see this is the abnormal P wave here. And because of the PAC, we can see the blood pressure lines is a little bit narrower than the normal patterns. This is only from the saturation monitor. We can record of the pulse of the pulsations and the ECG patterns. And here we can see many times the PVCs around here. Then unfortunately, patient would have a large R on the T wave, which means that R on T has appeared on this patient and should be very clinical ill. So we should be very careful and we have to start something. And this is the VT and VF patterns here. And also this is the flutter, atrial flutters, something like this. It's a very typical one. And whenever the patient has reached the above the 20 who has received the Fonta operation, those kind of patients should get very easily sick. So whenever we see the flutters, we have to stop it as soon as possible if the patient had only single ventricular circulations. This is the pictures of the atrial flutters, which includes the IRAT in addition to flutters. Re-entry through the right atrial inches line was also something like this will happen, and the tricuspid vent valve re-entry will be. And it should be 2.1, and atrial cases are often not maintained. It's often 2 as well. And does not suffer AT, but just only reactive against the DCs. So whenever we see those patients, we just put the ATP to make the AV delay and to be sure that this is the flutters. So then we will just move on for the DCs. And majority cases will be stopped in time. Those DC would work very nicely. This is the, please look at the here, normal curious pattern sneak inside here. And this means that signs of suspected are actifiers when the front and rear beds are shaking or when the curious interval is too narrow. So it may be mislead our findings of the ECGs here, uh, here, 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 here. The look always for the normal QRS patterns. So how about the other types of the tachycardia arrhythmias? The atrioventricular regressive tachycardia, we call them AVRT, so-called WPW syndromes, and is a candidate for if the patient had a heart attack, we should move on thinking about the ablation catheter treatments. If we know that collateral contact reentry would happen, the atrial case is often non-maintained, so the majority of the patient might have the blood pressure will be dropped. But the cell is will react for the ATP and it will stop for the disease. But looking at the ECC, it's clearly easy to distinguish because they always have a delta waves from the soon after the P wave. And this is the pictures of the very typical double P syndrome here. They always the QRS intervals should be using the same conductions. So it should be the same rhythm, the same hour interval will be observed here. So the atrial case is not often maintained, but we could always see the reentry outer ventricle node and the collateral conduction track, something like this. So here, white QRS, as it doesn't go through the his or Parkin's fiber, the reentry of the atrial ventricle node and collateral conduction tracks, the atrial case is not often maintained, but it's stop for ATP and stop for disease. So what happened to the AV node regression tachycardia? We call them AV NRT, which is the both two common reasons, two common types of the SVT, because one is the AVRT and the other should be AVNRT. This is the mostly well known as the adult cases. There is always a fast and slow conduction pathways in the atria, which means that there is a reentry of the AV node, and the majority is the atrial cake is not maintained. Also, it will stop for ATP and stop for disease. So normal people would have multiple conduction pathways in the atrium, and normally it takes fast conduction paths, but no slow conduction paths, which means that it will not make the reentries. But in this type of the patient, always the fast and slow conduction pathway should be something working to make this kind of the tachycardia. And here, as you can see, this is a very typically ECG here, which means that there should be a P wave, something around here, retrograde P wave, but it's always hidden within the QRS. So something should be very near to the QRS here, but we could not able to distinguish. Here is the typical flutters ECG patterns, including atrial flutter and ART. The reentry through the right atrial ECG line here, which means that tricuspid valve reentries are there, so the atrial cakes are not often maintained. It's often 2 to 1, and doesn't stop for ATP, but it reacts for the disease. Here we could able to differentiate based on P wave locations. Differentiation is necessary because the treatment differs depend on the diagnosis. If the R and P, we could see the retrograde P wave is short, which means that it's a possibility of AVRT or double PW, or maybe AVNRT. The others, the QRS of the R and the P wave is a little bit long R and P, maybe it's a possibility of AT, or maybe it's just only the sinus rhythm. So this is another picture of the P wave locations, which mean that jet varies from case to case, with P waves appearing before and after the QRS. And QRS and P wave are sometimes disjointed, which means the atrioventricular dissociation would happen. Okay, how we could identify the P wave? First of all, just we have to do 12 inductions ECC first, and then because the monitoring ECC does not show it the P wave properly. So always we have to perform the 12 inductions ECC. This is the most precise way to diagnosis. As you can see here, just looking at V1, you can see the P wave just behind the QRS. And if we do the atrial pacing lead to electrolyte, you can see the patterns of the QRS is very narrow, but still it doesn't seem that there is no relationship between the both waves, right? So what is the adenosine triphosphate dissociation hydrate means for ATP? Whenever we see the SVT, we are recommended to use the ATP first because it would delay the conduction, AV node conductions. But we should be very carefully because some pediatricians might use the ATP very slowly, which does not mean nothing, because we have to put this kind of drugs in one beat. So whenever we place the ATP first, just insert ATP, and always we have to boost it with the saline, maybe 5 to 10 cc's to reach in one beat into the atrium area. And we have to ask those methods. We call them two syringe techniques. And if we do just on the drip fashions, it would not move so much. It wouldn't work so much. So only we have to say to put the ATP in one beating contractions. So if we will respond to ATP, the every RT, WPW, or every NRT, it will just stop it because every node is included. So every node delay would happen, and it will not circulate it anymore. So once the tachycardia arrest would happen, it will return to the sinus rhythms. So in such cases, the ATP administration itself is also treatment. But also in some situations, the arrhythmia should recover soon after. So here these pictures of the atrial tachycardia or atrial flutters. As you can see that the every node delay would happen, but still the arrhythmia would not happen. But still you can see the P wave here. And this means that you will be able to understand what is happening on the inside the heart. Here you can see the delay of the QRS. So it means that the RR intervals is prolonged. This is the picture of the jet. And once we put the ATP, but it doesn't react nothing. So conclusions is heart rate is a sign that reflects the conditions. The tachycardia in particular is a sign of infections, or maybe it's a worsening heart failure, and also a trigger to notice arrhythmia. The new premature contractions are sign of infections or worsening heart failure. For tachycardia caused by the hemodynamic collapse, first just start the chest compression and just second electric shock. But please be careful when choosing between asynchronous and synchronous. So summary of the step to detect pathological conditions. First, just pulse rate. A pulse that is too fast or too slow may be pathological, which means that exceptional is sepsis, example is that this sepsis, infections, and worsening of disease. Please check that the RR interval, QRS to QRS interval, is regular. If the RR interval regularity may be the arrhythmia, for example, the PAC, PUC, atrial fibrillations. A pulse with too little RR variability may be arrhythmia. For example, for the atrial tachycardia, double P double syndromes. And please check to see if the P wave procedure cures. If it does, it's an arrhythmia. So this is the end of the talks. So thank you for the keep attention for my talks. Thank you very much.
Okay, thank you very much, Dr. Ueda. I hope that the lecture about the electrocardiogram will really give us a new knowledge, or maybe rehearsing or refreshing knowledge. So we have uh, uh, professors and doctors from pediatric cardiology, from anesthesiology, and radiology and anesthesiology. So we have so many wide range of profession in specialistic here. If there's any question, you can ask the question or raise hands, please.
Hello, Dr. Wira, can you hear me?
Dr. Windak, please,
Uh,
Dr.
uh,
Windak.
my network is not good. So I want to ask question. Thank you for excellent lecture, Dr. Ueda, with your interesting schematic picture of the heart and of the pulse. I want to ask about the tachycardia, the abnormal tachycardia. What is the most high cases? I mean the cases at your clinic or at your hospital about the tachycardia in baby. In baby, I mean in like 1 month, less than 1 month. Is it the first question is the etiology of the tachycardia? Is the group is for non-structural heart disease? I mean, no congenital heart disease. The second question is about tachycardia in acute condition for the very ill baby. I mean, like in the ICU, sometimes we have very sick baby without any cardiac abnormality, but maybe the baby uh, uh, sepsis has have sepsis, and then they also put in the mechanical ventilation. But the tachycardia, I mean, is more than the normal heart rate according to their age, like maybe more than 170, but the baby is only less than 1 month. That's two questions. Thank you.
So thank you for a very informative questions, because as you mentioned that during the fetal time, looking at the fetal echo, there is a very high possibility of who has no heart anomalies inside, but still have a premature contractions such as the PAC or maybe the PVC. In some cases would have the flutter. Maybe some cases would have a long QT prolongation. But fortunately, most of them would have diminished after birth. So the only thing we could do is just keep very carefully monitoring. So within, I think, 1 week or 2 weeks, the incidence of the arrhythmia would get much more decreased. But in some cases, for controlling the flutter or maybe the SVT, we should put on the first line or second line medications to put the, for example, channel one blockers or something like that, or maybe we have to make put the digoxins, or maybe we have to put the beta blockers to control the heart rate. But those prognosis is quite well. So just waiting for maybe a couple of few months, we'll be able to diminish, maybe to decrease the amount of the drug. But still, at looking at the, as I mentioned, that if the arrhythmia would happen after the open heart surgery, that's a completely different issue, because mainly if the patient who had open heart surgeries looks very well while the general anesthesia is working, when the patient is deeply sedated, the arrhythmia wouldn't happen so frequently. But once you reduce the amount of the anesthesia, and then patient would seems to be getting awake and start to move it. At that time, the heart rate will suddenly arose and then show the PAC and the PVC, and suddenly it moves to the very sick, for example, jet, or maybe AT would happen, which is very difficult to treat of them. So whenever we see that, I always understand that basically there is a background of the heart functions is not recovered as before the open heart surgeries, which means that it should take time to fully recover. So I would like to ask to the surgeons to keep very sedative again, and then put the, if possible, to lower temperatures, to let them the it should be how do you say, the uses of carrier will be decreased. So we should keep it very calmly and put in very deep sedative, and if possible, the hypothermia would work in sometimes. But still, we cannot tell that it should be worked nicely, because if the patient had for example, a splenic syndrome, maybe post-splenic syndrome, and if had a patient had a AV valve regurgitation, their presence of the arrhythmia would have a very bad prolonged prognosis, which means that the possibility of get survived should be very low. So we should be very careful. But at this present time, there is no, I think, efficient way, just only waiting for the heart functions recovery. But still, if the heart functions does not recover, I think there is no possibility to get the patient survive. So that's the worst things. And so the only thing that we can is is to reduce the as you know, the open heart surgery would have to use the artificial pumps. So the durations of the artificial pumps will depends on those the prognosis. If you use the baby pump, artificial pumps, so long the heart functions will not recover properly. So we have to reduce those kind of the open heart surgeries. How do you say? If there's many things to do, for example, to do the elbow valve plasty, and do the correct the internal uh, abnormal structures, or maybe we have to replace the artery and pulmonary artery for something like TGA, or something else. The possibility of receiving those kind of those lethal arrhythmia will be very high. So we have to keep it very balanced, which procedures works very well or not. So that's at that time we just ask for the surgeon to do the only palliations and wait for the uh, heart function recovers a little bit, and then we will go for the corrections of the heart surgeries. Does it make sense for you?
Yes. Thank you for very nice answer. But if about the group of baby without any structural heart disease in the ICU, and they have tachycardia more than the age-related normal heart rate. I mean, less than 6 months, maybe that the baby uh, in the ICU with heart rate around until 200, but no structural heart disease. We know that we must find out if there are like fever and anemia or anything. Maybe you can give us your suggestion for this group of baby in the ICU.
Mm. Oh, I think I think it's very important to do the rule out with every possibility, such as if there is a accentuated thyroid hormones levels is high, we should uh, we should maintain to keep it normal levels, or maybe if there's some endocrine abnormal findings, we should get have to ask uh, for the other consultant to help us. And if also if there is some kind of the those infections, or maybe we have to take care of them. But still, if we will be able to use the beta blockers, a very small amount of it, maybe I think that it should be get uncontrolled. But still, we have to be very careful. So propanol maybe works very nicely, and also digoxins will works uh, if doesn't happen to react against the beta blockers. So, but still the prognosis wouldn't be so worse. I think the most majority will get survived. But still, if the patients live in a very distant place, maybe the control in those kind of cases would be very difficult, because even in my case, daily practice, I have some cases for traveling using the ship, and it will take maybe 1 day, or maybe half a day, 1.5 day to reach to our hospital, and it should be very difficult even for us to control the heart rate. So at that situation, um, uh, when the patient got very unstable, I have to ask the patient to uh, to how to say to change the life place in the near to the our hospitals. So in some cases, it should be very difficult, as you mentioned, but still the prognosis should be not so bad. The majority will be just uncontrollable, I think.
Okay. Thank you for your clear explanation.
Okay, thank you, Dr. Winda. I think Dr. Felix want to ask or discuss about the patient. Well, Dr. Felix, do you want to share the screen?
Yes, Dr. Wira, Professor, may I share a case of the ECG?
Yeah, please. You can share the screen.
Can you see the picture, Professor and other colleagues? So actually, this is a patient's teenagers. She had a plastic anemia, and he came to the hospital with a little bit shortness of breath, but not ventilated. But she's also had anemia. But at that time, I just want to check the ECG rhythm, and it shows like this. I had no clue at that time, and not not after, I think less than 24 hours. Yeah, less than 24 hours. She had a sudden death. I asked one of my colleagues. My colleague said that it might be a Burgundy syndrome from this ECG pattern. May I ask your your opinion, Professor? Thank you.
Thank you very much.
Bruganda syndrome.
Yeah.
Yeah, yeah.
Thank you very much for a very interesting cases, because when I saw this ECG V2, and it's looked like a saddle patterns, which Brugada syndromes looks V2. Can you show us the uh, much more larger? V2 is very typically for the Brugada syndrome. And also, when I see this VCC patterns at the limb leads, the old leads show that low voltage of P wave. 1, 2, 3, APL, APR, AVF. Those of the T wave is very low. So it means that the contractions of the ventricles might be diminished. But still, the majority of V2 is saddleback patterns. I think it's the very typical of Brugada syndromes. And if I see this one, how to say, I'll check one these upper side. Yeah, as you can see, the QT interval is a little bit prolonged, and also the T wave is low voltage of each leads. You see the 1 and 2 and maybe 3. Can you show us the 1, 2, 3? Yeah, and the AVL or AVR or AVF here. As you see that AVF T wave is inverted, and looking at the V1, the T wave is a little flat, but still you can see V2 at saddleback patterns. So QT is prolonged, and the limb leads of each leads are very low voltage, and the QT interval is prolonged, and we can see the saddleback patterns, which might see that the functions of the ventricle may be diminished at this point. And I don't know exactly how the aplastic anemia, the end of the aplastic anemia cases would show the ECC patterns, but due to these findings, I may feel that the contractions will be very severely diminished or not. Did you had a chance to check the echoes of what's the heart beating or
Unfortunately, the patients could not done the echo, Professor.
So this kind of the situation, maybe are there any sign of the congestions, or for example, the SVC is dilated, or you can see pulsations of the venous line, or the heartbeat should be very prolonged and very weak. What I feel from this ECGs. So maybe if you feel the liver, the liver size should be enlarged or something. Did you check the X-ray or abnormal X-ray or something? Or are there any signs of congestions?
I'm sorry, Professor. I did not remember the chest X-ray. I have to take a look on the medical record. I just
Well,
remember the ECG pattern like this.
So this patient has a very typically prolonged QT interval, which means that the conduction delay is always happening at this point, which means that it has a very diminished contractions of ventricle, which uh, uh, I'm very how do you say? I'm worried about that whether the patients have a severe contractions of the ventricles.
Can severe anemia cause this arrhythmia like this, Professor?
I'm sorry.
Can severe anemia or severe low of hemoglobin can cause this arrhythmia?
If as you know, if the hemoglobin is below the 5, that means the O2 delivery is so low, which means that it should be 1/3, 1/4 of the normal healthy patterns. So if the patient is higher than teenage, I think he could complain that he will feel very easily fatigued or something like that. So I think the O2 delivery is very low compared to the healthy person if the hemoglobin is lower than 5. And what's the hemoglobin of this patient?
Sorry, Professor, I do not remember.
It's a very interesting case, I think. So from these cases, we can learn that whenever we see such kind of findings, we have to be very careful to examine these cases. And I think it's quite reportable. So I would like to ask you to write down something like articles, if possible.
Thank you, Professor. I think I can look on the medical record, the data, so I can add some data for this. Thank you, Professor.
Thank you.
Yeah, I think if Dr. Felix wants to proceed with the discussion, I can share the email for Dr. Ueda, so you can contact him right away.
Thank you, Dr. Vira.
Thank you.
Yeah. I think we still have about 10 minutes. Oh, Dr. Winda. Please, Dr. Winda.
Yes, thank you, Dr. Wira. Thank you, Prof. Ueda. That was interesting tip from Dr. Felix. I want to ask a further question about the severe anemia caused by any other condition, such as maybe uh, infections, severe infections, or sometimes we have babies with only 6 or 7 hemoglobin level due to severe infection. I want to ask for the management for the severe anemia. We should sometimes we consult. There was a request for cardiology evaluation. So in like hemoglobin level less than I think maybe 8, should we give uh, uh, uh give Taylor or need inotropic support because the baby is very sick and they have a hemoglobin level still less than 8, and then meanwhile there will be plan for blood transfusion. What is the initial management for this case? Thank you.
I think that's a very interesting issues because, as you mentioned, that if the hemoglobin level is low, that means the O2 delivery is very decreased, so the patient might be get very sick. If it's happening to be chronic, I think the patient could bear, even in such a low level as such as the, for example, leukemia, treating leukemia, those patients will be showing in a very low, but it's still move is very gradually, and that's why the patient would have bear in such situations. But still, if because of the infections, the anemia would happen to be very fast, so I think the patient would feel very uncomfortable or very easy to get fatigued. So in such situations, we have to adjust the amount of the hemoglobin first, but still during those phase, I think it's a good option to use the inotropic agent first, and then give the blood infusion. And then if the patient who showed in uh, the conditions had improved, at that time we should be able to stop the inotropic agents. I think it should be only used for 1 day or maybe 2 days. It should be enough. But in some cases, because of the very severe and prolonged anemia, the blood infusions might worse because of the retentions of the blood may have a congestions. And at such situations, I think we should give the diuretics maybe is to help the heart functions. But at that moment, we should use the inotropic at the same time simultaneously. So it's a good thing to use those inotropic in a very rapid phase and very short times. So it should be wise to use it. And I think so. If the patient has a low blood pressures, of course, the first thing is to use the saline, to rapid saline first, and then we should use this to maintain the blood pressure. We should continue to put the blood infusions next. And then if something wrong or if the patient seems to be not so well, then inotropic will do something good things for those kids. I think there is no reason to hasty to not use such kind of drug. What do you think about it?
Yes. Thank you for your very interesting answer, because sometimes you have to know that in Indonesia the iron deficiency anemia is very high prevalent, even in the pregnant mother. So after the baby born, these small babies has actually has already has iron deficiency anemia, and then when these small babies get sick and very sick in severe infections, so the hemoglobin level would drop until 6 or 7. That's why I think maybe uh, meanwhile we give antibiotic, and we in the acute situation we can give inotrope, like what you already said. Thank you.
Thank you, Dr. Winda. So maybe next question is from Dr. Rubiana. Dr. Ruby, silakan dokter.
Sebentar. Thank you very much, Dr. Weda. Thank you, Dr. Ira. Dr. Weda.
Thank you. Thank you very much.
Okay, Dr. Weda, can I ask your comment about digoxin in for treating the paroxysmal SVT? Do you still use that one? Because in Indonesia, sometimes it's not easy to find ATP. What is your opinion about digoxin? And then second question, what is your opinion about the vagal maneuver in a patient, especially in infant? How effective is that? Thank you. And then the third one is I'm very interested in the case that has been presented by Dr. Felix is very interesting, right? Because but again for Dr. Felix, if it is true Brugada, the patient death because of the Brugada, but you have to check also for the family. Probably you have to send the whole family to check. Probably they may need the challenge test for to exclude whether any history of the Brugada in the sibling as well and the family. Thank you.
Thank you. So,
First question.
The first question is digoxin. Do you still use digoxin
so do you use like,
or SVT for termination of SVT?
is it possible to digoxin uses
In the main carrier
drugs?
That's the question.
Well, I think the digoxin has a very careful uses because if you use too much, it maybe have a poison would happen, right? But still, if you use it properly, I think it's a very good way to control it. But still, I don't know the exact reason because the young staff on my institution wouldn't use digoxin so much. So it's becoming a trend to use these other drugs such as the beta blockers or something else. Well, that's a trend. I think it's because of the trends of the adult, how to say, adult professionals wouldn't hate to use the digoxins, but still, I believe digoxin is a very good agent to use this one. But still, is the ATP is very difficult to use because
Yeah, it's very hard to find ATP, especially in a not central hospital. So some of our colleagues find very difficult to find ATP in their center. So that's why some of our colleagues use amiodarone or sometimes try lanoxin to control the paroxysmal SVT.
amiodarone.
Sometimes they have to use that one because they don't have that one. They don't have beta blocker IV as well as ATP.
Oh, so would you use the flecainide?
The flecainide is also not easy to find. We only sometimes we can find it in a Tokopedia. So e-commerce.
E-commerce.
Oh,
Yeah. That's our limitation in managing SVT, especially in a small baby. Okay. So what any comment about the vagal maneuver? Is it still effective for infants, especially because patient after they discharge from the hospitals, we still suggest the parents to learn about the vagal maneuver just to try to terminate the SVT in their young baby. What is your comment about that one?
I couldn't hear the last words.
Okay.
Vagal maneuver for very small infant. Is it still effective?
Fungal.
Oh,
vagal maneuver.
Oh, you do it.
Yeah. How?
Where are they?
Yeah, Dr. Ruby wants to ask how, but
Oh, I think to perform in the small kids, valsalva maneuver, it should be very difficult, right? Because the kids should be screaming or maybe unstable. The touching the neck, if this patient gets stable, it should be works very nicely. But still, the majority, I haven't tried because I don't have any confidence to solve by only by the Valsalva maneuver. So if you have a good experience, please, I would like to ask you how to do it. So that's the thing I want to ask you. Are there any way to perform effectively or what is your experience? Would you perform the Valsalva maneuver in the small kids?
Oh yeah, okay, thank you. Because some literature or some studies still said that some we still have the option to teach the parent especially to how to manage, how to do the vagal maneuver in their small infant before they bring the patient, before they bring their kid to the hospital for to the emergency. One that I read is just put a small pack of ice pack at the head. Some yes, but some of the kids work with that maneuver, but I still don't have a lot of experience. Yeah.
Well, ice pack, I think is good for the patient if the patient had reached the age of 5 or 6. It should be works nicely in some cases, but still, if the patient is the infant or maybe the smaller, the patient would keep screaming or crying so hardly. So it means that it wouldn't works properly. So I haven't tried the ice pack because whenever I use the ice pack in the small kids, the parents would be very shocked to use such kind of the method. And yeah, I'm sorry, I do not have good experience using ice pack and also basal maneuver, but I'm lucky to understand that some of the cases white works in a proper way. So if you give me much more information, I will just follow your style. So,
Thank you.
Yeah,
Yes. Yeah. Most of the cases we just rub the neck, very gentle,
Mhm.
and some only one case that we try to put gently just ice pack. Yes, because that case was 80, which is stubborn with anti-arrhythmia. Yeah, it didn't work. But I don't know if it is the cause of FNRT. I don't know. Still limited case. Thank you.
Thanks so much.
Thank you, Dr. Ruby, Dr. Ueda, and audiences, professor, doctors, and colleagues. I think we have finished our first session for today, the lecture. And we can open again the link at 30 p.m. So we can have rest and maybe salat and lunch. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang.
Thank you very much.
Thank you very much.
Thank you so much, Dr. Weda. Very nice.